Thank you. Good afternoon. I want to be mindful of the time too. I have the honor of being the last presenter today. I would like to thank you all and the other presenters. It's great to see some presenters that I went on the historical tour with last year. My name is Lauren Ghazal. I'm a nurse practitioner and PhD candidate from NYU Myers College of Nursing. And today I'll be presenting a work in progress, which is my dissertation study, exploring multi-level factors impacting quality of life in working young adult cancer survivors. I put my email here if you have any additional questions given the time. So I want to acknowledge the funding that I received through the Pilot Project Research Training Program and the NIOSH T42 at Myers. I also want to acknowledge my dissertation committee, Dr. Victoria Vaughn Dixon as my chair, Dr. John Merriman of NYU, and Dr. Sheila Santacroce of UNC Chapel Hill. This presentation begins with a brief overview of young adult cancer survivors, who are those diagnosed between the ages of 20 to 39, and survivorship begins from the time of their diagnosis until the end of their life. Most recent estimates from the American Cancer Society report an estimated 90,000 young adults are diagnosed with cancer each year in the US. Among some of the most common types of cancer found in this population are hematologic cancers, so leukemias and lymphomas. And for this population, the diagnosis of cancer comes during a key transition period, which is young adulthood. And this poses additional challenges to cancer survivorship, as there may be interruptions of expected milestones during this period, such as finishing education and establishing employment, along with the day-to-day challenges of managing the demands of a serious illness such as cancer. Young adult cancer survivors face increasing disparities in their oncology care, from delays in initial cancer diagnosis, being diagnosed at later stages of disease than other age groups, and historically having low rates of participation in clinical trials. I wanted to clarify some of the key terms that you'll see throughout the presentation, the first being workability, which is the balance between job demands and personal capacity relative to those demands. Work-related goals, which are defined as how a young adult cancer survivor understands why they are working and what they hope to achieve in their work. So for example, income, health insurance, meaning, or purpose. Financial health is a subjective appraisal of the overall state of one's personal financial situation. And lastly, quality of life, which in this study is captured as an individual's assessment of his or her own general well-being. The theoretical framework guiding the proposed study is adapted from the social ecological model and life course perspective shown in the figure here. The social ecological model includes the individual, microsystem, mesosystem, exosystem, and macrosystem levels. This study focuses on just the individual, microsystem, and mesosystem levels. And while important to quality of life, exosystem and macrosystem were not incorporated in the study, and instead will be a focus of future research. The life course perspective allows us to assess these levels at a specific time in the life course, here being the period of young adulthood, and how these systems interact during a complex transition in life, that is, young adults post-cancer diagnosis and active treatment. In this study, the individual level represents characteristics of the individual, such as their sex, age, race, ethnicity, income, symptoms, psychological well-being, workability, and financial health. The microsystem involves factors related to school, work, peers, colleagues, and coworkers, financial and social support, while the mesosystem is the interaction between both the individual and microsystem levels. Given the social ecological framework, we looked in the literature to see what influenced quality of life at these various levels. We know that young adults with cancer overall have poorer quality of life than their aged peers in the general population. In regard to individual level factors, young adult cancer survivors often experience higher levels of anxiety, depression, distress, and fatigue, poorer workability, and poorer financial health than their aged peers. Microsystem level factors include work and education and areas of support. Employment has been shown to enhance overall quality of life in these survivors, as it provides not just financial necessities such as income, but also meaning to one's life and a significant source of social support. Again, mesosystem level factors include the impact of cancer on young adult trajectory of work and/or career. A majority of young adult survivors are in work or in school at the time of their cancer diagnosis. However, in one study, 1/3 of young adults reported a negative impact of cancer on their ability to work, and they were more likely to stop working or to work only part-time throughout their treatment. Many young adults then have this opportunity to resume an interrupted life course and contribute to the workforce, but after a diagnosis of cancer may not be committed to the career they initially chose, ultimately impacting their quality of life. Despite continuing improvements in survival for young adults, the diagnosis of cancer during this time has negative psychosocial consequences that can affect quality of life. But overall, there is little evidence on how multi-level factors intersect to shape quality of life in working young adult cancer survivors. Thus, the purpose of my dissertation study is to explore the relationship of work-related goals and quality of life in young adults with cancer, with a focus on factors influencing quality of life at the individual level and work-related factors at the microsystem and mesosystem levels. The study-specific aims are shown here. Being a mixed method study, there was a quantitative aim, qualitative, and integrated aim. In a sample of working young adults diagnosed with hematologic cancer, this study aims to, and as read here, describe the relationship between patient-reported individual characteristics, work-related characteristics, and quality of life. Aim 2, explore symptom experiences, work-related goals, workability, self-identity, and perceived psychosocial needs through individual semi-structured interviews. Aim 3, the integrated aim, was to examine the relationship of individual and work-related characteristics to generate profiles of the work-related goals and quality of life relationship. And aim 2 is italicized here, as it was the first aim we tackled in the analysis and will be the focus of the presentation. A brief bit on our methods. Again, the study has a convergent mixed methods design with equal quantitative and qualitative components. The sample are 40 young adults diagnosed at 20 to 39 years with a hematologic malignancy. We employed maximum variation sampling on specific variables such as sex, race, age at diagnosis, and type of work to obtain as heterogeneous sample as possible. Participants were study eligible if they were between the ages of 20 to 39 at diagnosis, were diagnosed with a leukemia or lymphoma, were within 1 to 5 years of their diagnosis and at least 1 year since completion of active cancer therapy, were working and or attending school to any extent at the time of diagnosis, and with the ability to read and understand English. Participants were excluded if they were currently receiving active cancer treatment or had a life expectancy of less than 6 months. The study took place entirely online, which was planned well before the COVID pandemic, and which we were grateful for. We received IRB approval through NYU. Following IRB approval, we began recruitment, which was in April 2020. We posted study information such as the recruitment flyer and a short blurb about the study on several social media sites, including Twitter, Instagram, and Facebook, and on the pages of survivor groups. Study recruitment took roughly 3 months, which was consistent with previous literature on social media recruitment in the broader population of young adult cancer survivors. And we used DocuSign to obtain informed consent. Data collection was primarily through electronic means. Again, both quantitative and qualitative data were collected. Quantitative data included study measures collected on REDCap. We chose instruments that were psychometrically sound and did not place too much burden on the participants. But for the purposes of this presentation, I'm not going to go into each measure in great detail, just that there were 7 measures that captured study variables at the individual level, such as anxiety and depressive symptoms, and microsystem level, such as job control and workplace support. Qualitative data collection consisted of semi-structured one-to-one phone interviews through Zoom. The semi-structured format ensured consistency while allowing for in-depth narratives. And the interview guide that we used was based on the theoretical framework guiding the study with specific questions provided and suggested probes. We obtained a separate consent for audio recording, also collected through DocuSign. Interviews were recorded through Zoom and professionally transcribed. Participants were also given a $50 gift card as an incentive following completion of both quantitative and qualitative components. Because this is a work in progress, I wanted to show this figure of our study design and the procedures and products described for each phase of the study and where we are now. With the convergent design, we collected quantitative and qualitative data concurrently. Participants completed the measures and then within 2 weeks completed the interview. For data analysis, we analyzed qualitative data prior to the quantitative data, but at the same time in the study period. So we're currently at this phase, highlighted here with the red box. The rest of the figure shows that data will be integrated and interpreted in the final phase in the coming months. Analysis for AIM-2 is being done prior to AIM-1 to reduce the potential for bias in analyzing the qualitative data. And we're using MaxQDA for qualitative content analysis. An initial code book was developed based on the theoretical framework, interview guide, and meetings with content experts. We reviewed the transcriptions line by line and added additional codes as they emerged. Coding categories were then summarized, grouped into clusters where we identified themes that emerged from across these coding categories. And in analyzing the qualitative data, an idea for a strictly qualitative manuscript developed. This manuscript is in the process of being submitted to a journal with a strong occupational health focus. And the purpose of this manuscript comes from the second aim of the study to explore the post-treatment perspectives of work-related goals in a sample of young adult hematologic cancer survivors. The survivor's dilemma was identified as a theme, which was described as a multi-factor process of decision-making regarding survivors' current and future work and education. Young adult hematologic cancer survivors in the study were continuously weighing these sub-themes of perceived health and workability. So could they physically and mentally do their job? And then self-identity, do they want to do their job? And then financial toxicity, can they afford to do their job? These areas influence how they perceive their work-related goals. So briefly, next steps will be the quantitative data analysis, which we will be using Stata for, and then we'll look at differences between low and high workability groups and quality of life. And then we will analyze the final aim by integrating both the quantitative and qualitative data through the use of an informational matrix or joint display. We'll compare the quantitative data from AIM-1 with the qualitative themes from AIM-2, assessing where the results differ and the data agree, and how one form of data may expand upon the other. The result of this analysis will be a rich description of profiles that describe the work-related goal and quality of life relationship in this population. That is identifying a typology of how these young adult cancer survivors can be identified. So given the time of their diagnosis and improvements made in survival for cancer in this population, young adult cancer survivors have many work years ahead of them. We know they experience poorer quality of life compared to their peers. So one of the main implications of this study is that the results will yield important insight into the work-related influences of quality of life in this important population. Here are my references, which I'm happy to share later. And thank you all.
Thank you, Lauren. I don't see any questions in the chat box. Anyone wants to ask questions? Okay, Michael, please go ahead. Michael, you probably need to unmute. Oh, they did say impressive, Lauren, and meaningful topic, Michael said. Anyone having questions? Okay, Joanne has a question. How did your qualitative research add insights to your quantitative research?
Great question, Joanne. It's great to see you on here. And that's currently where we are, working to integrate the qualitative and the quantitative data. A mixed method study is a lot of work, and it's exciting, but we're excited to see what depth that qualitative research will bring to the quantitative findings. So I'll get back to you on that.